Hi, everyone. Welcome to The Open Mind, a lecture and film series that brings together thought leaders in science and culture for relevant and meaningful discussions about mental health issues. This series is proudly sponsored by UCLA's Friends of the Semel Institute for Neuroscience and Human Behavior and the Resnick Neuropsychiatric Hospital Board of Advisors. I'm Vicki Goodman, and it is my honor and privilege to introduce our two preeminent speakers for today's program, Dr. Charles Grob and Dr. Thomas Strouse. They will be speaking with us about psychedelics for human suffering, a new paradigm for the 21st century that is clearly a very popular subject because 1,737 people signed up for this program. But then who's counting? Dr. Charles Grob is a professor of psychiatry and pediatrics at the UCLA David Geffen School of Medicine and the director of the Division of Child and Adolescent Psychiatry at the Harbor-UCLA Medical Center. He has been pioneering research on psychedelics since the early 1900s, and along the way, he's met some very interesting people, but I'll let Charlie tell you about them. From 2004 to 2008, he was the principal investigator of the first study in several decades to examine the use of psilocybin treatment model for patients with advanced cancer anxiety. He has also conducted research into the range of effects of MDMA in both neurotypical volunteers and in a selected subject population of adults on the autism spectrum with severe social anxiety. He has also conducted a series of ayahuasca research studies in Brazil. Over the last 30 years, Dr. Grob has published numerous articles and chapters on psychedelics in the medical and psychiatric literatures, and he is the editor of Hallucinogens, a reader, co-editor of Higher Wisdom, Eminent Elders Explore the Continuing Impact of Psychedelics. I love the eminent elders. And co-editor of the recently published Handbook of Medical Hallucinogens. He is a founding board member of the Hefter Research Institute, a nonprofit organization that promotes research with classic hallucinogens and psychedelics to contribute to a greater understanding of the mind and to alleviate suffering. Dr. Thomas Strouse is professor of clinical psychiatry and the inaugural holder of the Maddie Katz Chair in Palliative Care Research and Education. He's also vice chair for clinical affairs in the Department of Psychiatry and Biobehavioral Sciences at the UCLA David Geffen School of Medicine. Dr. Strouse served as the chief medical officer of the Stuart and Linda Resnick Neuropsychiatric Hospital at UCLA from 2007 through 2021. He served from 1994 to 2007 as Director of Cancer Pain Management and Supportive Oncology Services at the Outpatient Cancer Center at Cedars-Sinai Medical Center, where he developed additional interest and skills in palliative medicine. He has spent his career working with medically ill adults coping with psychiatric and physical aspects of catastrophic illness. Along with his current efforts to promote palliative care clinical research within the UCLA health system, Dr. Strouse is a faculty member in the combined GLA-UCLA Palliative Medicine Fellowship and is actively engaged with UCLA's Operation Mend, a program for wounded U.S. servicemen and women. A few housekeeping notes before we get started. Today's program will be recorded. It will run for approximately 1 hour with the last segment reserved for your questions. If you would like to ask either of our speakers a question, please type it into the Q&A, which is located at the bottom of your Zoom screen, and we will do our best to get to as many questions as possible. We have a lot of viewers, as I mentioned earlier, so we thank you in advance for your patience and understanding. The program will be available for viewing on our YouTube channel beginning tomorrow. And that can be found at the friendsofthesemelinstitute.org. There you will also find a calendar of upcoming events, an extensive library of past Open Mind programs, information about our Friends Research Scholar Program that awards grants to early career neuroscientists, our Open Mind Film Festival, and our new Teen Advisory Council. Now, please join me in giving a warm Zoom welcome to Dr. Charlie Grob, who will be joined by Dr. Strouse a little later in the presentation. Thank you so much.
Thank you, Vicki. Appreciate that. So I will share my screen. Okay. Okay, so yes, a second here. Yeah, the topic for today is psychedelics, and this is a topic I've been quite interested in for some decades. For quite a long time, it was a marginalized issue within psychiatry and medicine, and now just in the past few years, suddenly the word is out, and there's been a considerable surge in interest and activity investigating these compounds, and even extending to changes in the law. So I will try to give an overview of the topic, and at the end I will spend a little time describing a new study that Tom Strouse and I have been working on and will be implementing in the near future. So let's see. That's better. Okay, my obligatory disclosures. So important to note that in spite of notable advances in our field, the rates of mental illness have been steadily increasing and are anticipated to increase even more in the coming decades. So even while expenditures have gone up, rates of mental illness have also gone up. We have a significant rise in suicide rates, also treatment-resistant depression those rates have soared considerably even before the pandemic. And with the pandemic, we're seeing even higher rates of mental illness. So the question really before us is, are we ready to look at some new and novel treatment models to address these significant concerns? In other words, are we ready for a paradigm shift? So a paradigm shift was a concept first developed by Thomas Kuhn, a philosopher of science, held professorships at UC Berkeley, Princeton, and finished his career at MIT. In 1972, he published a very important book called The Structure of Scientific Revolutions, and posited that what spurs radical changes in our understanding and in our treatment models really comes from a re-examination of our underlying beliefs or theory. And paradigm shifts are important changes that happen when the usual way of thinking about or doing something is replaced by a very new and different way. And I will return to this concept later in the talk. I find nomenclature a very intriguing issue. What do you call these drugs? They have such unusual effects, and there's been a rather vigorous debate really extending back to early in the previous century. The prevailing term within the culture is psychedelic, which is a translation from the Greek, ancient Greek, mind manifesting. The term psychedelic came about through a correspondence between Aldous Huxley, the British literary figure who spent a good part of his life in LA, and Humphrey Osmond, a distinguished British Canadian psychiatrist who did some of the early work with these compounds in the 50s. They were both dissatisfied with conventional nomenclature, so they were trying to come up with a new term. And Huxley wrote to Osmond, "To make this trivial world sublime, take half a gram of phanerothym," writing in verse. Phanerothym, one of the alternative terms. Osmond wasn't quite satisfied, and he responded, "To fathom hell or soar angelic, just take a pinch of psychedelic." And so the term psychedelic was born. Alternative terms include entheogen, which addresses the capacity of these compounds to facilitate powerful psychospiritual experience. hallucinogen, which is sometimes criticized for being an over-medicalized term. My friend Ralph Metzner really kind of helped me better understand it by pointing out that the Latin root of the term, of the word hallucinogen is hallucinare, which translates out as mind wandering, mind journeying, mind traveling, tripping, as it was. And there are other alternative terms. Psychotomimetic was an early term in this research, but then it was realized that with many subjects and with proper set and setting, people do not experience psychotic states. I've always liked fantasticants, a term created by Louis Lewin, one of the fathers of modern psychopharmacology, a German scientist, the early part of the 20th century. And you can see many of the other terms that have been tried. But, you know, I prefer hallucinogens in many respects when not talking about cultural issues. And here's an opportunity to plug my my book with Jim Grigsby, which I believe is the first formal textbook in the field, published by Guilford Press. So these, I'll try not to get too technical. Let me just point out that the classic hallucinogens chemical structure is very similar to the major neurotransmitter serotonin. They all have this indole ring and are all chemically quite similar. The discovery of serotonin and where it was in the brain, where the nuclei and the projections were of serotonin, was actually first elucidated by a distinguished psychiatrist, scientist named Daniel X. Friedman when he was chairman at the University of Chicago. Danny Friedman ended his career at UCLA as a professor emeritus in the late 80s and the early 90s. So UCLA had in many respects, had a role in the early history and evolution of this field. But it's the 5-HT2A subreceptor which is felt to be most responsible for the unique effects of psychedelics. Here are some non-classic hallucinogens. NBOM, which is active on the microscopic level, has been used as a substitute for LSD and blotter paper out in the black market and has caused a number of fatalities. So that's a very dangerous drug. Some of these compounds are chemically related to compounds that are more easily tolerated. Some of these are rather dangerous, starting off with NBOM. Another compound, salvinorin A, is a diterpene, not an alkaloid because there's no nitrogen. It was used in its plant form, used by the Mazatec as a agent to facilitate altered states for purposes of healing and initiation. And then there's ketamine and MDMA, both in the press quite a bit. I don't think I have to talk much about them, except there's considerable interest in their therapeutic potential. And ibogaine is the active alkaloid from the West African iboga plant, which is used by syncretic religion as part of their elaborate rites of initiation. Ibogaine has also been used as an addiction interrupter, but individuals interested in ibogaine treatment need to be aware that it has some cardiotoxic effects, so that they need to be studied and worked up properly before cleared. And also keeping in mind that access to ibogaine is not feasible legally in this country, but many individuals have gone outside of the country to Mexico, the Caribbean, to Europe. The Netherlands for a while provided this treatment, but not in the US. Many of these psychedelic compounds were first discovered in plants, have a long history of use by native peoples in their plant form. Psilocybe cubensis contains psilocybin. Lophophora williamsi is actually peyote, contains mescaline. Peyote is the sacrament for the Native American Church, which is protected by the courts for individuals with at least 25% native indigenous lineage. And Claviceps purpura is a fungus, an ergot fungus, which grows on rye, which contains lysergamides, similar in chemical structure to lysergic acid diethylamide, which is LSD. And this ergot was believed to be an element, a vital element of the ancient Greek rites of Eleusis, the sacrament Kykion, as it was termed, contained LSD-like chemicals from this ergot fungus on rye. A compound, plant compound I've devoted a considerable time and attention to studying has been ayahuasca, which grows throughout the Amazon basin. It's a decoction of two separate plants, Psychotria viridis and Banisteriopsis caapi. If you take either one on its own, they're inactivated in the gut by the monoamine oxidase enzyme system. But if taken together, there's a remarkable synergy, and the monoamine oxidase effects are inhibited by the monoamine oxidase inhibiting capacity of the alkaloids in Banisteriopsis. And mixing the Psychotria, which contains DMT, the Banisteriopsis, which contains harmala alkaloids, one ends up with the ayahuasca brew, which has been used for indigenous healing throughout the Amazon basin and is also the sacrament for a number of syncretic churches, most of which originated in Brazil. I studied one in depth, and the rites of this church, the UDV, to utilize this powerful hallucinogenic sacrament legally was challenged in the courts in the early 2000s. I was an expert medical witness for that case, so very familiar with it. And remarkably, the conservative federal judge ruled to protect freedom of religion rights. It was appealed to the appeals court in Denver and then appealed again to the Supreme Court in Washington, both of which ruled, the Supreme Court ruled unanimously that the União Vegetal, or the UDV, should have their right to take ayahuasca, even though it contained a Schedule I compound. They should have their rights protected under law when it's used in religious ceremony. We know that the use of plant hallucinogens extends back many millennia, long before recorded history. This is a sketch by an artist named Kathleen Harrison off of a cave painting in the Tassili Plain in southeast Algeria in the Saharan desert. This is basically a rock painting of a shaman, and you can see the mushroom protuberances around the shaman's limbs and torso, a beehive mask, which is important because honey was how these compounds were preserved over time in the absence of refrigeration. And the ancient peoples are known to have utilized these compounds. Really, this was among the first medicines, the great medicines for the prehistoric people, used for religious and medicinal purposes, initiation rites, and used by diverse cultures around the world, and had a profound influence on the evolution of various civilizations. The range of effects of hallucinogens, these are sustained altered states of consciousness, alterations in perception, mood, and cognition in an otherwise clear sensorium, not frank visual hallucinations, rather more visionary experiences with eyes closed. And these visionary experiences often play out a thematic theme. They tell you a story, often tied into the reason why you were having this experience in the first place. Similar to dreams, spontaneous epiphanies, spiritual states, and also in vulnerable individuals, psychotic states. And the significance of set and setting are integral to the outcome. When you optimize set and setting, you screen adequately, and you properly prepare individuals with an optimal setting, you are more likely than not to help facilitate a positive outcome, a therapeutic outcome in many cases, as opposed to not being attentive to set and setting, which is where individuals get into difficulty. There was a lot of interest in researching hallucinogens back in the 50s and 60s. Lester Grinspoon, a distinguished professor of psychiatry at Harvard for many years, reviewed the vast literature from the 50s and 60s until this research was put on hold in the late 60s, early 70s, and identified that over 1,000 papers were published in the professional literature examining the experiences of some 40,000 patients treated with these compounds. So there was a great deal of interest, and but unfortunately, our culture at that time in the mid-late 60s could not handle the individuals having these experiences. There was also the perception, I think accurate to some degree, of a public mental health crisis, particularly among young people who were ill prepared for these experiences, who took it in suboptimal conditions. And also these compounds were entwined in some pretty tumultuous culture wars going on in the late 60s. In a sense, it became the sacrament of the counterculture, and really was seen as really too problematic, and permissions to use these compounds in research were withdrawn. And by the early 70s, there was nothing going on in this country, nothing until a few colleagues and myself were able to start things up again in the 90s. So a long hiatus where these compounds were put on a shelf, not studied in any kind of manner, rigorous or not, but we have picked up the ball again and are moving forward, and I think that's a good thing. Back in the 50s and 60s, you could see some of these conditions that hallucinogens were used to treat individuals were some of the more difficult conditions you'll find within psychiatry. The treatment of alcoholism is as difficult now as it was some years ago when Bill Wilson developed AA, and it's still, in many respects, the go-to treatment recommendation for alcoholics. Of interest, Bill Wilson volunteered to be a subject in Sidney Cohen's LSD studies at UCLA in the 50s. Sidney Cohen was a distinguished psychiatric researcher and was so enamored of the experience that he recommended to the board of trustees of AA that they utilize an LSD model for subjects, individuals coming to them for help with their alcoholism. However, by that time, Timothy Leary and his colleagues were making a lot of noise, drawing a lot of negative attention to themselves, and the board of trustees at AA rejected Bill Wilson, the founder's advice. But you see chronic PTSD, there's been a number of MDMA studies which have shown quite impressive efficacy and good safety parameters with chronic refractory PTSD patients. OCD, obsessive compulsive disorder, another terribly difficult condition to treat. There have been studies at University of Arizona and now at Yale. NIMH is funding the Yale OCD treatment study with psilocybin, which is the first NIMH funded psychedelic treatment study in some 50 years. So the times are indeed changing. Also antisocial behavior, autism. We did some examination of autism in young adults, not kids, but young adults who had incapacitating social anxiety using an MDMA treatment model, got very good results published in the literature. And finally, an area that I've spent a good deal of time studying, and we're developing a new, more ambitious project, is the treatment of existential anxiety in individuals approaching the end of life. And in the past, we focused on cancer as the causative agent, and future studies are going to be opening up for more indications. Some of the early phase 1 studies, the first one to get off the ground was at New Mexico with Rick Strassman looking at DMT. Our group at Harbor-UCLA got permission in the early 90s to use an MDMA treatment model, study its range of effects. And there was also work at Miami with Ibogaine, and then our field work in Brazil in the early and mid 90s, examining the range of effects in adult subjects, and then in the early 2000s, doing a similar investigation in adolescents whose parents and often grandparents were members of syncretic churches that used ayahuasca, had permission to use ayahuasca as a psychoactive sacrament. And there was a request by the Brazilian judiciary that some objective investigators come down and examine the relative safety of young people joining their families for these experiences, so that we had that opportunity as well. A very important study, and a very important investigator out of Johns Hopkins, Roland Griffiths, replicated some of the work from the 60s, even the 50s, where they identified that individuals who had the best therapeutic outcomes were those who, during the course of their many-hour, often solo experience with a psychedelic, had a powerful psycho-spiritual epiphany, a powerful religious experience or mystical level experience. And what Roland Griffiths did was identify in his normal volunteer subjects that if you control the setting and the conditions for the taking the drug, you could fairly reliably predict a powerful spiritual level experience, which conveyed great meaning to subjects. So this is an important study because under optimal conditions, you can replicate an experience which has been associated with positive therapeutic outcome. So that's an important study. The mystical experience, or the psychedelic peak experience, a sense of unity, oneness, transcendence, time and space, a very positive mood, a sense of awe and reverence, powerful sense of meaning or philosophical insight, ineffability. It's very hard to put this experience into words. Paradoxicality, what you think you're seeing or experiencing may not be, it may be the inverse. And transiency, while you're in it, it's an eternity, but then once it's over, it's as if it occurred in the flash of an eye. So there have been some phase 2 studies, treatment studies. We did the first study treating cancer anxiety. We went back and forth with the FDA on a dose that we wanted a higher dose, that we kind of agreed to do a moderate dose. And this FDA had, I think, good reasoning, which was no one has worked with this compound in human subjects in more than 30 years. Let's be careful and focus in on safety, which we were happy to do. And we completed our study and we're quite pleased with the outcome. Subsequent to our publication, the group at NYU and Hopkins got approved to use a higher dose because we established safety, feasibility. They were able to get that higher dose and they got even better results than we did, although we got very good results. There's always been a controversy over what placebo control to use. I don't have to get into that. And subjects acted as their own control. We didn't want to randomize someone dying of cancer to a non-active treatment. So everyone was randomized to either the psilocybin treatment or the placebo treatment. We collected data for, then 4 weeks later, they came back for a second treatment and got the opposite condition. So if you got placebo the first time, you would receive the active drug the second time, although it was double blind. So neither the investigators nor the subjects knew for sure. It was sometimes apparent who was on what, but honestly, sometimes we were all fooled. So I think the blinded controlled studies are important to continue in this field. Open label may be easier to run, but you're missing out on really being able to demonstrably prove that the treatment has merits or not. So this is where we published our study in the Archives of General Psychiatry, at that time, the #1 impact journal in the field. We were very pleased by that. I think it showed that our work, as unusual as it was for that time, was perceived as of interest with some of the leading figures in psychiatry. We found a drop in depression sustained over 6 months. We also found a drop in a lowering of anxiety, which again sustained over the long haul. And what's so interesting about this treatment is not that you could facilitate a rapid improvement in status, but it can sustain over many, many months without additional psychoactive drug treatment, perhaps additional therapy fitted for this treatment model, but again, finding this sustained effect, which the other groups found as well, that anxiety can be lowered for many months, mood can be improved, I think marks this treatment as quite distinct from others where you have to administer on a regular basis. Here's just the publication of the NYU group and the Hopkins group. They got very good data. They got actually statistically stronger data than we got. I think reason being they got permission to use a higher dose. We're going to be using a higher dose for our new study. And into some other applications, phase 2 treatments. A few months ago, Michael Bogenschutz at NYU published work he'd done at NYU and previously at New Mexico, kind of resurrecting the psilocybin treatment of alcohol abuse model. Peter Hendricks at Alabama has treated cocaine and crack addicts. Matt Johnson has treated people with cigarette addiction, which is an application I don't think anyone imagined prior to, and also importantly, NIDA is now funding a follow-up study for Matt's study at Hopkins to study the smoking cessation model even further. And that's the first NIDA, National Institute of Drug Abuse, funded study on psychedelic treatment ever. So that's important. Then the depression studies in London, in England, at Imperial College, run by Robin Carhart Harris. Here you can see some of the depression data, that the higher dose clearly a better effect, improvement of mood. And then phase 3 multi-site studies, which are a prelude to drugs coming out on the market and being available more widely. This phase 3 studies include the MDMA study run by MAPS of chronic post-traumatic stress disorder, 2 studies looking at refractory depression by 2 private business entities that are somewhat in competition with one another. The FDA has given breakthrough therapy status to this treatment model, and until recently, when NIDA and NIMH each funded one study, it's been entirely private funding. Until these for-profit companies came along, it was entirely philanthropic, and now there's the for-profit motive, which I think puts a different kind of slant on the field, and I think needs to be monitored carefully. So paradigm shift, conventional paradigm is we got to administer these drugs as we've been doing for years. We got to administer them daily for weeks, for months, for years, and it's hypothetically we're ameliorating a presumed pathologic brain state, although it's often very hard to provide that scientific demonstration, and insight and attitude are not necessary for in terms of outcome. And here's a different paradigm altogether. Are we ready for a paradigm shift? And with my the title for the talk, I also had a question mark in there. So are we? This is the question. I'm not saying we are. I may be intrigued by that question, but the real question is, are we ready for a paradigm shift? And a psychedelic psychopharmacology paradigm, the drug may need to be administered on only one occasion within the context of a psychotherapy, or on a few times spread apart by weeks or months, again, within the context of therapy. These compounds loosen defenses, facilitate insight. They may facilitate a powerful mystico-mimetic, mystical level experience, which appears to be predictive of positive therapeutic outcome. There's very careful monitoring. You can see 2 sitters in there with the subject. They check in every hour to see how the subject's doing, and will be available at the end for some more in-depth processing. But for the most part, they're there just to ensure safety and all of the conditions of the treatment being adhered to. So Michael Pollan, the very prominent writer, wrote a very popular book on psychedelics. For many weeks, it was the #1 on the New York Times bestsellers list, and that really kind of blew the lid off this field. And suddenly, it was a much talked about. It went from being a marginalized topic to a very much talked about topic. So I think Michael has, a lot to do with the resurgence of interest and popularity of psychedelics. And this is now extended over to changes in the law. And ballot initiatives have passed in a variety of cities around the country, starting with Denver and then Oakland, Santa Cruz, Washington, D.C., very interesting, Seattle, where they have decriminalized these compounds. A couple of states, Colorado and Oregon, are moving towards legalization, are moving towards developing a process that will allow for the use of psilocybin containing mushrooms used in a psychotherapy. They haven't put together their what you're going to need to be able to do this, what the credentials are of facilitators, but there's a lot of work that's happening in these two states, and it's likely to spread to other states, including California, which will have a similar initiative on the ballot in 2024. So mushrooms are now decriminalized. Now what? Boy, that's the $64,000 question. Now what? These are very, very powerful compounds. They have the capacity to be of great value for healing, but they could also cause serious problems and damage, particularly in individuals who are vulnerable and not prepared, and taking it in suboptimal contexts, taking too high a dose or mixing it with alcohol or other substances. I think this is, I think we're going to be hearing a lot more about both the positive path forward as well as what the concerns are in this area. The FDA, have been very, very struck with how proactively positive the FDA has been with really trying to understand how the range of effects of these compounds, so they could develop optimal, policies and rules. And here, this is a poster. They invited myself and some of my colleagues to really spend a day with high-level people at the FDA, just telling them what the range of effects are and how it might be optimally used and what we've learned from our research. And I think they've taken much of what we had to say to heart. And I think the FDA has been remarkably fair and judicious in how they have functioned in this process.
Dr. Grob, this is probably a great time to transition to some of the audience Q&A.
Oh, okay. I'm going too fast, huh? You want me to kind of hold off on showing?
I think if you could conclude here, that would be great, and then we'll spend the last 20 minutes or so in a discussion.
I'll shoot through real quick. There have been very, very significant outlays of money for psychedelic research centers at some of the leading universities around the country. Hopkins kicked it off, receiving a $17 million donation, which is now creating more research at Hopkins. Mass General the same, Yale, UCSF, and UCLA under hopes to develop a psychedelic research initiative that Tom might be able to tell you a little bit more about. There's the controversial issue of the for-profits getting involved. I can kind of skip over that. And look, and this is kind of relative to our latest study. This will be looking at the end of life, looking at subjects in palliative care. And we know that the one universal experience every individual who's ever been born has is everyone will die, and many of us will experience existential suffering. And is there anything that could be done about that? We know that about a little less than 15% of adults with end-of-life stage illness have major depression. A great deal more have clinical demoralization, upwards to 35%. So we focused in on demoralization as a primary variable for our new multi-site study. These are just the studies that have looked at using a psychedelic treatment model, all using psilocybin with end-of-life conditions. Our study, NYU, Hopkins, and UCSF. This is a pragmatic trial of psilocybin treatment and palliative care. It'd be multi-center, 5 sites probably. We aim to recruit upwards to 100 to 112 subjects, and we're looking at real-world conditions. We're going to be partnering up with palliative care specialists and oncologists. We were approved for a moderate high dose. We have some flexibility we can use in dosing. There'll be an active control, which will also cause an altered state. And we're going to be using a meaning and purpose therapy, which comes out of the existential psychotherapy world, which is a good fit. And our primary outcome measure will be looking at demoralization, secondarily depression, anxiety, quality of life, etc.
I think we need to wrap here. So
I'm wrapped. I'm done. This is my last slide. These guys are kind of looking out after us, making sure we do this right. These are mushroom stones from 1,000 years ago in Central America. And these are just issues that I think are important and we need to examine. And I would just only say that I think the future of this field really rests on how well we can establish and maintain strong safety and ethical parameters. And you can see some of the other issues that we need to examine. So that's my talk. I think I got it in, if not within the time span, close to it. So
thank you, Dr. Grob, very much.
Introduce Tom Strouse to lead a discussion.
Dr. Grob, thank you. I don't know if the audience is aware, but you've really provided a perspective from more than 4 decades in the field in a short time, and we are very grateful for the wisdom and the broad view. There are more than 30 questions in the chat. We have about 15 minutes left, so I don't think we're going to get to all of them, but I'm trying to sort of synthesize themes here. I think one of the themes, a number of questions have come in about the safety of various psychedelics in patients who have known coexisting mood disorders, psychotic illnesses, addiction problems. I realize that's a difficult question to answer sort of generically, but I wonder if you would want to say anything about safety and who is the candidate.
No, there isn't. There are exclusionary. My longer talk provides what excludes you from these studies, and that includes having a history of a psychotic illness and even having a first-degree family member with a history of schizophrenia or bipolar disorder. In terms of addiction, I mean, there's always concerned individuals will misuse, but as I alluded to, these compounds, this treatment model does appear to have very strong potential to facilitate treatment of addictive disorder. So it's kind of a double-edged process. On the one hand, there's risk. On the other hand, there may be unparalleled benefit that could be explored and could be utilized.
Thanks. There have also been a number of questions specifically about what we know or don't know about microdosing of psilocybin for depression.
Right. Yeah. What we know is that there have been some very, very interesting and very well written anecdotal accounts of individuals who felt their lives were positively changed through a microdose regimen. However, the several studies that have gone to the effort of developing a controlled study with the placebo wing have not been able to find a strong signal for therapeutic efficacy. So I think the microdose, it sounds good, it sounds great actually, but it still awaits definitive proof.
As a child adolescent psychiatrist, Dr. Grob, you might be particularly well suited to comment on the question of whether there's clinical trials evidence or safety data for kids and teens and young adults who may have significant mood or anxiety disorders and who may be contemplating exposure to psychedelics.
Yeah, well, I'd be very careful regarding administration of these kinds of drugs to kids. The only exception might be looking at older teenagers who have serious conditions, let's say chronic PTSD, who have failed conventional treatments. There may be a window there, but for the most part, I don't think we're anywhere near developing treatment model for minors. I think we have to be very careful about this issue. This kind of blew up in the 60s and did play a role in the shutting down of all research.
Thanks. There have been a number of questions about which among the psychedelics, including ketamine, which helps answer the question, are currently legal and available for above ground use in ordinary clinical settings, that is not in a clinical trial setting. What is actually legal and FDA approved? Really,
except for ketamine, nothing. And ketamine is a dissociative hallucinogen. It's not quite a psychedelic. So, unless you live in, let's say, Oregon or Colorado, then they have legalized mushrooms or decriminalized.
And so what's the difference between decriminalization and legalization?
Well, I think decriminalization means if you get busted, you're not going to get punished, but legalization means it's the path really to be able to administer these drugs and treatment, and individuals do not have to access them and take them in a clandestine manner.
Thanks. I'm moving quickly here because there's so many questions coming in. We've had some questions about what you might call psychedelic polypharmacy? That is, do we know anything about the co-administration of more than one of these agents at any one time for particular problems?
I think we know to be really careful, and there's a tendency in our culture for people, to want to take a lot of whatever it is, or mix things up, be their own, research, do their own private personal science. I think there are potential hazards in this, and I would caution people from polypharmacy, because that's one of the risk factors for adverse outcomes.
Another really interesting question, and it in a way picks up on what you mentioned in Roland Griffith's work about mystical or spiritual experience. Do we know whether having a mystical or spiritual experience is a necessary part of benefiting? Let's say you have depression and are in a treatment-resistant depression trial. Do you have to have that mystical or spiritual experience or some dissociative experience to get benefit?
I don't think you have to have it, but if you do, it does seem to infer greater likelihood of positive outcome. So, what did William James say, the founder of American psychology around 1900? He said, the best treatment for dipsomania, which is an old term for alcoholism, the best treatment for dipsomania is religiomania. So he wasn't necessarily talking about compounds inducing spiritual experience, but I think it's been recognized for some time that powerful spiritual experiences can facilitate positive changes in individuals' lives. And these spiritual experiences can be caused by powerful compounds like psychedelics, or they could happen spontaneously or under other different non-drug conditions.
You said in one of our research meetings a few days ago, and I found it rather memorable, that probably a college dorm room is not the optimal set and setting for an initial or first psychedelic experience. One of the participants said, can you share more about what a good set and setting look like?
Yeah. Be careful with the college dorm room. I went to college in the 60s, and I saw stuff that shouldn't have been going on, and some bad outcomes as well. But no, the optimal set and setting is first of all being with someone who is not altered, who is not has not taken any drug, and has a clear perception, and has all of his faculties or her faculties. Someone who's there with you throughout the entire time, who will monitor you, make sure you're okay, make sure you don't wander off, get into trouble, who can answer unforeseen circumstance, like if there's a sudden knocking at the door. Someone under the in an altered state isn't going to want to have to deal with that, but having a sitter can. Also, proper screening, making sure you're not allowing anyone with serious vulnerability to have this experience. Also, it's really important to focus when you're preparing. It's good to process with someone, a therapist, someone or a close friend, and to examine what is your intention. Why do you want to have this experience? Because more often than not, the experience will reflect what the intention was. And for individuals who are having visionary experience with eyes closed, having these almost like waking dream experiences, thematic visions, when you process after the session is over about that visionary experience, you'll find more often than not, it reflects to one degree or another the intention to have this experience in the first place.
Thank you. We've also had some questions about psychedelics for non-psychological symptoms like severe chronic physical pain. Do we have any evidence to inform that?
There was some alluring anecdotal evidence back even going back to the early 60s with Eric Cast in Chicago. But the modern studies, our study, Hopkins and NYU, did not come up with a strong effect where pain was ameliorated. But there are some other studies that's cancer pain. That may be a different entity than kind of orthopedic related pain, where I think there's a greater sense that these compounds may have relevance. But there have been no completed published studies as of yet.
And what about for sort of subtle or maybe not so subtle troubles with memory and cognition, either in the context of dementing illness or chronic brain fog, like with long COVID? Any data there?
No strong data. There's been some speculation that, and I think some demonstration in the laboratory that there are some neuroplasticity effects on a cellular level, and there's been some suggestion that this might be of value for individuals who were experiencing deficits in cognition, but no, the kind of controlled study you need to demonstrate whether this is real or not, that study has not been rolled out as of yet.
There have been a number of questions about dosing. One was what dose were used in your studies, and the other essentially is what dose is necessary for depression. Can you comment on those?
Yeah. Our dose, our common dose was, maybe between 14 to 20 milligrams. For the new study, we're going to be working more in the range of 25 to 30 milligrams. Hopkins and NYU were working in a higher dose range. So, and with the depression studies, it's a moderate to moderate high dose. I think around 25 milligrams seems to be, this is pure synthesized, laboratory synthesized psilocybin. 25 milligrams seems to be considered at this point, at least, the optimal dose.
Although, and so that's different than 25 milligrams. That's different than 25 milligrams of pulverized mushroom for people who might be.
Oh my God! Yeah, of course. Yeah. The mushroom is it's entirely different. It also contains additional alkaloids, not just psilocybin, but also psilocin, baeocystin, which has really received very little rigorous study. So mushrooms are, and different mushroom species have different concentrations of these different alkaloids. It would be fascinating to study mushrooms. A quite renowned, very, very well thought of ethnomycologist in Oregon, Paul Stamets, has been pushing for some time to get some focused studies on the range of effects of mushrooms, both in normal volunteers and in treatment settings. But again, this field is just getting off the ground after being shut down for decades because of the turmoil of the 60s, and we're just picking it up again and moving forward. So there are a number of areas which need to be explored, but are awaiting the investigators and the funding they need.
Do we know anything about hallucinogens or psychedelics and their interaction with meditation practices?
Oh, good question. Observation I made, having lived through the 60s and 70s, was that a number of my contemporaries who had been very drawn to psychedelics, but found it after some time to be destabilizing, drifted to a Vipassana meditation model practice. And a number of them I know spent some time in Southeast Asia studying Vipassana meditation and came back to this country as leaders of the Vipassana group. If you talk with them, people like Jack Kornfield, you can hear their stories about as teenagers or in their early 20s, engaging significantly in the whole psychedelic scene, but then realizing that enough was enough and they needed to work on getting grounded and kind of reestablishing a sense of stability and processing and integrating what they learned in those powerful psychedelic experiences. And that integration process can go on for quite some time, months, years, lifetimes.
Any risk of inducing something called serotonin syndrome with any of the psychedelics? And maybe explain what serotonin syndrome is.
I published a paper looking at some case studies of individuals who were on SSRI antidepressants who took ayahuasca. And when the MAOI function of the hormonal alkaloids in ayahuasca can impair the metabolism of serotonin and lead to a serotonin syndrome, which can be pretty scary for the individual and those around him or her.
So that might be a particular concern in somebody who was on prescription antidepressants and then was delving into.
Otherwise, if you're on an SSRI and you take psilocybin or you take LSD, it will not induce a serotonin syndrome, but it very likely might attenuate the effects, lessen the intensity or the strength of the effects.
And how about SSRIs and MDMA? Do we know anything about that?
Again, there's an attenuation effect. But that being said, for our new study, if someone is on an SSRI, we're not going to take them off it because that's going to be could be destabilizing in and of itself. So, and we feel we're using a high enough dose that it could address the attenuation effects the SSRI might be having.
We have just a couple of minutes left, so I'll try to get a couple more questions in. Again, these are wonderful questions, and I'm sorry there are too many for us to cover. Do we have any information about the uses of psychedelics in people with eating disorders?
It'd be a really important area to study, except for some kind of theoretical papers, like also that had presented some patients with body dysmorphic disorder with positive outcomes in a psychedelic treatment. There have been no rigorous controlled studies looking at anorexia or bulimia for that matter. So, but it's a great area to look at in large part because our conventional treatments are limited often.
And I think probably the last question will fit in, has to do with transient versus durable effects. The question is about ketamine when used for an antidepressant, that it may have only a brief benefit.
Right.
But
we're using ketamine as our active control. And what we anticipate is both the ketamine group and the psilocybin group will have approximately 1 week improvement of their mood measures. However, after that 1 week, the anticipation is the ketamine effects will subside and they'll return to baseline in regards to mood status. But the psilocybin effects, we believe, will sustain over time. We've established a 6 month, it's at least 6 months of sustaining the antidepressant and anxiolytic effects. And some of the Hopkins data even suggests a longer persistence of therapeutic outcome. So there you have it. Lightning question round.
You did great.
Tom is a pro at lightning rounds.
Right.
Dr. Grob, thank you so much for sharing your vast wisdom and knowledge with all of us. I don't want to use a pun, but this was a mind-blowing experience. Really, it was fascinating, and we really, really appreciate you taking the time to speak with us today. And it really was a very meaningful and relevant program, and very popular one as well. So thank you so much. And Tom, you are moderator extraordinaire. You can do this job anytime that you would like.
Very kind.
I'm happy to relinquish that role to you. I want to thank everybody for tuning in today, for the privilege of your time. We are very grateful to our Open Mind audience and look forward to seeing you at future Open Mind programs. So thank you very much, everybody. Good night.
Bye-bye.